within a very short
Thank
time.
you. Thank you.
It's quite touching. I will call after this event. Thank you. All right, Florence, you can start.
Good evening, senior colleagues and colleagues. So today, Dr. Eugene Bafi Ampofo will be taking us on 2023 ESC guidelines on acute coronary syndrome. So Dr. Eugene, you have the floor. After your presentation, we'll have our questions and contributions made. Thank you so much.
Thank you very much. Good evening, consultants, senior colleagues. I'll be leading today's presentation on the 2023 ESC guidelines on acute coronary syndrome. Kindly pardon my low voice. I'm hypoglycemic, but because of the time in Ghana is 6, I had to present. So the ESC presentation, we all know there's class of evidence, and that will guide the discussion and the recommendation. So just as a reminder, class 1 is evidence and or general agreements that are a given treatment or procedure is beneficial, useful, or effective. Class 2, there's conflicting evidence and or divergence on opinion about the usefulness or efficacy of the given treatment or procedure. Then for class 2, we have 2A and 2B. 2A mainly favors the treatment. 2B is on the other side. Usefulness or efficacy is less well established. Then 3, clearly evidence or general agreement that the given treatment or procedure is not useful or effective, and in some cases may be harmful. So this will guide the recommendations that we'll go through. And these recommendations are informed by data, and the data is also graded based on the level of evidence A, B, C. A, data from multiple randomized clinical trials or meta-analysis. B, derived from a single randomized clinical trial or large non-randomized studies. Then C, more of consensus of opinion of the experts or small studies, mostly retrospective studies or registries. So on that note, acute coronary syndrome, as we all know, is a spectrum, and it comprises unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. And presentation may vary. You may have patients presenting with the first time with an acute coronary syndrome with heart failure as a complication. So they present as with a complication. They may present in cardiogenic shock. They may report with cardiac arrest, or they may come with chest pain or variable descriptions, which may be sharp, retrosternal, heaviness in the chest, burning sensation, and variable. So when a patient comes with chest pain of acute onset or sudden onset, and you are thinking of acute coronary syndrome based on the description the patient has given, the patient is classified initially based on the ECG findings into a non-ST elevation acute coronary syndrome or STEMI. And this is an ECG descriptive diagnosis where the ST elevation MI is defined by the presence of ST elevation in 2 contiguous leads that meet definition for STEMI by age and also by gender. So by age and gender, we mean for patients who are male less than 40 years in V2 and V3, you're looking at ST elevation of 2.5 millimeters and above from the J point. Whereas if they are above 40 years, you are looking at ST elevation in V2 or V3, 2 millimeters and above, and in any other lead, 1 milliliter. Whereas in females, you are looking at 1.5 millimeters at V2, V3, irrespective of the age, and 1 milliliter in the other leads. So if that ECG criteria is met, then you say the person has STEMI based on the ECG. However, in the absence of that, then the patient may have a non-ST elevation acute coronary syndrome, which may be an unstable angina or non-ST elevation myocardial infarction at the end of the final evaluation. The distinction between the unstable angina and the non-ST elevation MI comes in with the presence of high troponins, which in this case, the recommendation is high sensitive troponins. So for unstable angina, the troponins will be negative, whereas for non-ST elevation myocardial infarction, the troponins will be elevated. To establish a diagnosis of myocardial infarction, the definition of myocardial infarction is still based on the fourth universal definition of myocardial infarction, which
Sorry,
defines
Dr.
myocardial
Asamoah,
infarction.
please can you mute your mic?
Sorry about that.
Which defines myocardial infarction by the presence of a rise or fall in the HS troponins above the 99th centile of the upper limit range, which is defined necessarily by the lab, the assay, the 99th centile. And so that is the ruling criteria for the myocardial infarction. Then if the patient fulfills the components as described in the fourth universal definition, then you say there's myocardial infarction, i.e. chest pain consistent with ischemia, ECG changes consistent with ischemia, imaging showing new regional warm motion in a territory consistent with an acute coronary syndrome or ischemia, histopathological evidence, etc. So if a patient comes, this is what when you're suspecting acute coronary syndrome, it entails. So this is what I explained. So we will get to know that if a patient is coming, the ECG is expected to be done at the first medical contact within 10 minutes. So this is what I've essentially explained. And always remember that the ECG that is not taken in isolation. You have to consider the clinical context and whether the patient is stable or not. And this will inform your evaluation. So when you have a patient who you've made a diagnosis of STEMI, what is the way forward? So this is like an overview before we go into the recommendation. So you ask yourself whether the patient is in a facility, whether you are seeing the patient in a facility that can offer PCI. So the treatment for STEMI is revascularization. And one mode of revascularization is percutaneous coronary intervention. And so if you've seen a patient in the facility and that facility can offer PCI, primary PCI, where primary PCI is defined as having a coronary angiography with PCI or stenting without a prior fibrinolysis. So that's primary PCI. If the facility can do that, then that is preferred and as the strategy. And you should be able to do that from your door to your wire crossing in less than 60 minutes. That's the goal. However, if it's in a facility where you cannot do PCI, then you ask yourself, can this patient get access to PCI in less than 2 hours, 120 minutes? If the person can get access to that, it's good to refer the patient for primary PCI. So it's good to refer that patient to that facility after initiating your initial medical therapy for the primary PCI. However, if the facility is more than 120 minutes away, such that the patient cannot get there within the 120 minutes, then it's good to offer the patient fibrinolysis or thrombolysis if there is no contraindication to fibrinolysis, and then still refer the patient to the facility that can offer coronary angiogram with or without PCI, because the patient may require a rescue PCI, which is essentially when your PCI is not your thrombolysis is not successful. And a successful thrombolysis or fibrinolysis is defined as having a resolution in the ST segment elevation of greater than 50%, greater than or equal to 50% in 60 to 90 minutes. So if that is not, you don't achieve that, then the patient will need a rescue PCI, as in a coronary angiogram with PCI based on the assessment. However, you still need to consider early coronary angiogram post-fibrinolysis or thrombolysis within the 24 hours. So it's good to still refer. And if you make a decision to thrombolyze or offer fibrinolysis, then you are expecting it to have gone within with the time 10 minutes. So that is the general overview. Remember that this is considering STEMI, that is from onset of chest pain to time of arrival less than 12 hours. After 12 hours, there are indications to still consider primary PCI, which include ongoing chest pain, hemodynamic instability, presence of fatal arrhythmias or post-cardiac arrest. And we all know from the Oates trial, as much as possible, there is no benefit after 48 hours of patient as having a STEM. Now, with respect to the non-ST acute coronary syndrome or a non-STEMI, if you make the diagnosis, the decision to intervene is dependent on some risk stratification. So if your patient is very high risk, which is defined as hemodynamic instability on shock, recurrent ongoing chest pain refractory to medical treatment, acute heart failure, presumably from ongoing ischemia, and the other factors define the mechanical complications, then this patient is essentially is like a patient who has had a STEMI in its sense. So that patient requires immediate invasive strategy, which is coronary angiography and PCI if the obstruction is amenable to PCI. So that is within 2 hours, that patient needs to get to the cath lab. However, if the patient has features of high risk, not very high risk, defined by the presence of risk score of greater than 140, transient ST elevation, dynamic ST segment, or T-wave, etc., then the patient will go and still have an coronary angiography with possible PCI, but within 24 hours, which is 2 hours to 24 hours. Less than 24 hours, less than 2 hours is the very high risk group. So this is the general pathway, but essentially every patient with non-STEM, even if low risk, will get to know it's advised to have an angiography before discharge. So this is just a summary of it. So you have a patient in the right clinical context, abnormal ECG, you've assessed, you've made a diagnosis of STEMI or non-ST elevation acute coronary syndrome, you've risk stratified. We all know STEMI is primary PCI if indicated, no contraindications, and in less than 120 minutes reach. If not, then you consider fibrinolysis and rescue PCI or early angiography with possible PCI. Very high risk non-ST elevation ACS is treated just like STEMI, immediate angiography with or without PCI, less than 2 hours. And high risk, we have early angiography with possible PCI, which is 2 hours to 24 hours. And as part of the medical management, we all know that you have to consider the dual antiplatelet therapy. We will come to know the role of P2Y12 inhibitor in terms of the recommendations. You also have to have anticoagulant therapy, and the options have been stated: unfractionated heparin, low molecular weight heparin, bifaloridine, fandoparinus, and also the modes of revascularization, PCI if it's amenable, or cabbage if it is not amenable to PCI. Also, you have adjuncts in helping you to improve and achieve complete revascularization, and also secondary prevention, the lipid lowering, smoking cessation, cardiac rehabilitation, risk factor management, psychosocial constraint, etc. So this is a general overview of the ACS, and we'll go into the recommendations. So in the 2023 ACS, there were new recommendations, and the new recommendations were in these categories. One, looking at antiplatelet and anticoagulant therapy. If patients presenting with ACS stop dual antiplatelet therapy to undergo cabbage, it is recommended they resume the dual antiplatelet therapy after surgery for at least 12 months. And the class of recommendation is 1, the level of evidence is C. In older ACS patients, especially those with high bleeding risk, clopidogrel as the P2Y12 receptor inhibitor may be considered with its associated recommendation and the class and level. So I will not be repeating the class and the level since it's visible. Now, with respect to antithrombotic therapy regimens, in patients who are event-free after 3 to 6 months of dual antiplatelet therapy and who are not high ischemic risk, single antiplatelet therapy, preferably with a P2Y12 receptor inhibitor, should be considered. So these were informed by several trials which were looking at trying to shorten the duration of dual antiplatelet therapy post-PCI, and that informed the recommendation of 3 to 6 months. People who have read the papers may argue that the stents that were used in those trials are not the kind of stents that we tend to use most of the times in developing settings. And so whether this is applicable is another thing that we can discuss later. However, it is not cast in stone. You have to have a balance between the patient's ischemic risks and the bleeding risks, and the fact that the patient has been event-free. It's not everyone getting 3 to 6 months of dual antiplatelet therapy instead of the initial recommendation of 12 months. You should balance it with the ischemic risk and the risk of bleeding. And we know several factors influence the ischemic risk, the number of stents, the lesion type, diabetes, CKD, etc. So there should be a balance and a discussion, preferably with a team, to make a decision on that. P2Y12 inhibitor monotherapy may be considered as an alternative to aspirin for long-term treatment. So typically, for long-term treatment after the 12 months, there has been discussions on whether you can continue with aspirin or P2Y12 only. The evidence now is tilting towards P2Y12 monotherapy after cessation of the dual antiplatelet therapy. In high bleeding risk patients, aspirin or P2Y inhibitor monotherapy after 1 month of dual antiplatelet may be considered. And if we all remember, it's mainly a balance between bleeding risk and ischemic risk. So we always have to look at the patient in perspective. And if you look at the class of recommendation is 2B, it tells you there are dissenting opinions. In patients requiring oral anticoagulation, withdrawing antiplatelet therapy at 6 months while continuing the oral anticoagulants may be considered, which makes sense because you are trying to balance the risk of bleeding against the ischemic risk. Now, de-escalation of antiplatelet therapy in the first 30 days after an acute coronary syndrome event is not recommended. So that is clearly not recommended. Now, with respect to cardiac arrest, we all know that as part of post-cardiac arrest care is evaluation of neurological function and prognosis. So evaluation of neurological prognosis not earlier than 72 hours post-admission is recommended in all comatose survivors after cardiac arrest. Transport of patients with out-of-hospital cardiac arrest to cardiac arrest center according to local protocol should be considered. Then with the technical aspects of invasive strategies, in patients with spontaneous coronary artery dissection, PCI is recommended only for patients with symptoms and signs of ongoing myocardial ischemia, a large area of myocardial angiopathy, and reduced antegrade flow. We know that for spontaneous coronary artery dissection, mostly the management is conservative, and so you only consider PCI with the following that was mentioned earlier. And intravascular imaging should be considered to guide PCI in terms of defining significant lesions is 2A, and for vessels that are ambiguous, corporate lesions, you are not certain, intravascular imaging can also be used, but that is 2B. Now, with respect to acute coronary syndrome in a patient with cardiogenic shock, instead of there has always been the discussion on whether you stent both the infarct-related artery or the corporate vessel in addition to the non-corporate vessels. And there have been trials that have looked at that. Now, the recommendation is staged PCI of non-infarct-related artery should be considered. It means that not necessarily in the first primary PCI, you should stage the stenting of the non-infarct related artery. In this, that's a recommendation, is 2A. Now, in multivessel disease, when patient is hemodynamically stable, it is recommended that PCI of the non-infarct related artery is based on the angiographic severity. So if patient is not hemodynamically stable, and the non-infarct, you've stented the infarct-related artery, and the non-infarct related arteries have qualified, you may consider to stent them within that index PCI. Invasive epicardial functional assessment of non-corporate segments of the infarct-related artery is not recommended during the index procedure. Now, with respect to complications, implantation of a pacemaker is recommended when high-degree AV block does not resolve within a waiting period of at least 5 days after the MI. And it's a class 1 recommendation. Cardiac MRI imaging should be considered in patients with equivocal echocardiographic images or in cases of high clinical suspicion of LV thrombus. That is 2A. So in a setting where cardiac MRI is not available, I think this recommendation gives us a bit of room, because there's always been a situation where you do an echocardiogram and you suspect there may be an apical thrombus, but it's not certain, it's not clear. And the question has always been, should we be pushing patients to do cardiac MRI? Or if we think based on the clinical suspicion, the presence of an anterior MI, we should go ahead and anticoagulate. It's been a challenge. I don't know about colleagues in Nigeria, but cardiac MRI is very expensive in Ghana, and currently I think it's only one facility that reports cardiac MRI, and reports can take as long as 2 weeks before you get official reports. Following an acute anterior MI, a contrast echocardiogram may be considered for the detection of LV thrombus if the apex is not well visualized on echocardiography, and that is 2B, telling us that if we are not willing to do it, we are not really denying these patients the best of care, because they are dissenting opinions. In selected patients with high degree AV block in the context of an anterior wall MI and acute heart failure, early device implantation may be considered. So in this case, we are looking at devices that may be CRT D or CRT P. That's also a 2B. In patients with recurrent life-threatening ventricular arrhythmias, sedation or general anesthesia to reduce sympathetic drive may also be considered. That's also a 2B. Now, with respect to comorbid conditions in the context of acute coronary syndrome, it is recommended to base the choice of long-term glucose lowering treatment on the presence of comorbidities, including heart failure, CKD, and obesity, which I think is something that we are already doing based on the recommendations when it comes to the management of diabetes with glucose lowering medications, where we are looking at the presence of high atherosclerotic cardiovascular disease risk or established ASCVD risk, and also the presence or absence of CKD. Now, for frail older patients with comorbidities, a holistic approach is recommended to individualize interventional and pharmacological treatment after careful evaluation of risks and benefits. And this is something that obviously is considered even with or without guidelines. That is the approach when we are seeing patients. An invasive strategy is recommended in cancer patients presenting with high-risk ACS with expected survival of 6 months at least. So basically, you have a patient with malignancy, cancer, has ACS. The question is, what is the benefit of stenting or offering PCI or revascularization to a patient with malignancy? The recommendation, if you know the life expectancy or survival is going to go beyond 6 months, then you have to offer it. And if the chemotherapy or the treatment being offered to the patient is also contributing to the ACS, then the recommendation is to temporarily interrupt that treatment. That is the level of recommendation. The class is 1. Now, a conservative non-invasive strategy should be considered in ACS with poor cancer prognosis. And aspirin is not recommended in patients with cancer if the platelet count is less than 10,000 per microliter. clopidogrel if it's less than 30,000 per microliter, and for prasugrel or ticagrelor if it is less than 50,000. It is not recommended. Now, with respect to long-term, it is recommended to intensify lipid-lowering therapy during the index ACS hospitalization for patients who were on lipid-lowering therapy before admission. Secondary prevention, we all know, is critical. The importance of statins and now PCSK9 inhibitors and the other medications that help lower LDL. We all know for a patient who have had an acute coronary syndrome, the target LDL will be less than 1.4 millimole per liter. And if there's recurrence, you will have to target secondary targets such as the non-HDL, and you may have to intensify your LDL to even lower than 1.0. Low dose colchicine may be considered, particularly if other risk factors are insufficiently controlled or if recurrent cardiovascular disease events occur under optimal therapy. That is 2B. And also combination therapy with high dose statin and ezetimibe may be considered, also 2B, meaning that typically most people will want to maximize the statins before they consider additional therapy, and as depending on how much the patient tolerates. But there has been the arguments to start two medications. Mostly people have recommended starting with ezetimibe when we know that based on the person's levels of LDL, the target LDL will not be achieved in the next three months or 8 to 12 weeks or 4 to 12 weeks, or depending on which guideline, whether using ESC or the AHA. So people add ezetimibe from the beginning to statin if they notice that they are unlikely to achieve the target based on the estimated percentage reduction with high intensity statins alone. Now, with respect to patients' perspective in acute coronary syndrome, patient-centered care is recommended by assessing and adhering to individual patient preferences, needs, beliefs, ensuring that patient values are used to inform all clinical decisions. So I think this is very applicable in our context. So it's a class 1 recommendation. And as clinicians, patient's autonomy is key. So we cannot go against patient's autonomy. We can only give informed decisions for the patients to make their own choice. It is recommended to include ACS patients in decision making and to inform them about the risks, adverse events, radiation exposure, alternative options. Decision aids should be used to first. So I think there's something we do routinely or ideally we are supposed to be doing, but it's being captured in the recommendations. It is recommended to assess symptoms using methods that help patients to describe their experience. Using the teach back technique for decision support during the securing of informed consent. So essentially letting the patients to repeat, to explain things back to you for you to see whether the patient really has understood it or not is recommended. And patient discharge information should be provided in both written and verbal formats prior to discharge. So discharge summaries is important, and copies given to patients. Adequate preparation and education of patient discharge using the teach back technique or motivational interviewing, giving information in chunks and checking for understanding should be considered. And assessment of mental well-being using a validated tool and onward psychological referral when appropriate should be considered. And this is actually part of the cardiac rehabilitation that you need to offer patients with acute coronary syndrome. So those were the new recommendations that were added. Now, what recommendations were revised from the 2021? So in the 2017-2020 versions, we are going to look at the recommendations for imaging for patients with suspected non-ST elevation acute coronary syndrome. So the 2020 version said, in patients with no recurrence of chest pain, normal ECG findings, and normal levels of cardiac troponins, but still with suspected acute coronary syndrome, a non-invasive stress test for inducible ischemia or a CT coronary angiogram is recommended before deciding on an invasive approach. So basically, you have a patient who literally has not fulfilled the criteria or by definition for the ACS, but you still suspect this patient may have an ACS. Then the recommendation was to do a non-invasive stress test or a coronary angiogram, CT coronary angiogram, not the invasive. But in the current recommendation, it's similar, but I think it's the wording. So in patients with suspected ACS, non-elevated or uncertain troponins, no ECG changes, and no recurrence of pain, incorporating this CT coronary angiogram or non-invasive stress imaging test as part of initial workup should be considered. So they've reduced the level of the class. It used to be the non-invasive inducible test, the stress imaging was 1, but now it's 2A. So they've actually downgraded it. Now, with respect to the timing, so an early invasive strategy within 24 hours is recommended in patients with any of the following high risk. So the high risk parameters were described. It used to be a class 1 recommendation, but now with the 2023, it's a class 2A. So basically that one was also down regulated. Then with respect to the use of P2Y12 inhibitors as part or pre-treatment for STEMI, a potent P2Y12 inhibitor, prasugrel, ticagrelor, or clopidogrel, if these are not available or are contraindicated, was recommended before PCI and maintained over 12 months, unless there's contraindication for the excessive bleeding risk. So it was a class 1. But with further data, it shows that pre-treatment with the P2Y12 receptor inhibitor may be considered in patients undergoing, so it's not compulsory, it's a 2B. So basically, you're not pre-treating a patient before primary PCI with a P2Y12 in STEMI. There's dissenting views, it's a 2B. Then with respect to long-term antithrombotic therapy, after stent implantation in patients undergoing a strategy of dual antiplatelet therapy, stopping aspirin 3 to 6 months should be considered, depending on the balance between the ischemic and bleeding risk. So I think it's similar, but this time around they put in event-free after 3 to 6 months, who are not high ischemic risk. Then single antiplatelet therapy should be considered. So the key here is event-free and they are not high ischemic risk. Then you consider single antiplatelet therapy, and the data seems to be supporting when it comes to single antiplatelet therapy in long-term antithrombotic therapy, the P2Y12 inhibitors. With respect to out-of-hospital cardiac arrest, post-ROSC, delayed as opposed to immediate angiography should be considered among hemodynamically stable patients without ST elevation successfully resuscitated after out of hospital. So if a patient had a cardiac arrest and post-cardiac arrest, you ran your tour, you are able to establish that the patient had an MI, but without ST elevation, hemodynamically stable. The recommendation was still to do angiography. However, with the 2023, if they're hemodynamically stable with no evidence to support an ST elevation MI, coronary angiography, immediate coronary angiography is not recommended. Then in the 2020, targeted temperature management, TTM, which is done to help preserve neurological function, maintaining temperature between 32 to 36 for at least 24 hours, was indicated in patients who remain unconscious after resuscitation from cardiac arrest. Now, the temperature control here in the 2023 says that we should continuous monitoring of core temperature is recommended, but they are recommending a cutoff of not greater than 37.7. However, this is the ESC recommendation, but if you look at the ACLS recommendation in terms of the AHA, the temperature of 32 to 36 post cardiac arrest in patients who are unresponsive and not obeying command is still maintained. But this they specified greater than, it shouldn't be greater than 37.7. When echocardiography is suboptimal or inconclusive, an alternative imaging method should be considered. It was a 2A, it's been downgraded to a 2B. And routine revascularization of non-infarct-related lesions should be considered in STEMI patients with multivessel disease before discharge. So that was a 2A. However, from the complete trial and other trials that have been done, it shows that complete revascularization was associated with better outcomes. So just that most of the data did it as a stage procedure, not necessarily within the index PCI. However, here the recommendation is complete revascularization should come in either during the index PCI or within 45 days. But the index PCI, the decision to revascularize the non-infarct related artery or the non-complete vessel should also be informed by the earlier recommendations, i.e. the severity of the non-corporate lesion and also the patient's risk of complications such as contrast nephropathy, etc. Recommendations for acute coronary syndrome with respect to comorbidities, glucose lowering with targets to be so when patient had glucose levels of greater than 10, the recommendations was to bring it down, but to avoid hypoglycemic episodes. And it's the same thing, just that here the 2023 did not give a particular value. They are saying glucose lowering therapy should be considered in patients with ACS with persistent hyperglycemia, while episodes of hypoglycemia should be avoided. But the level of evidence, the class of evidence is the same. Now, we're now going to look at, so we've looked at the new recommendations, the ones that were reviewed. So now, what is the guidelines in totality? So with respect to evaluation, and please, if I may be pardoned, just 2 minutes. I keep getting a call from the hospital. Let me just call and I'll get back to you, please. Just 2 minutes.
What I will do is that I will drop you at the low junction. Okay.
Hello, sorry. So with respect to the clinical evaluation and diagnostic tools when it comes to ACS, it's recommended to base the diagnosis and initial short-term risk stratification of ACS on a combination of history, symptoms, vital signs, and other physical examination findings, ECG and HS troponins. So I think this is something that we do routinely, but it's been emphasized. And ECG is recommended at point of first medical contact to be done within 10 minutes. That's a class 1. Continuous ECG monitoring and the availability of a defibrillator capacity is recommended as soon as possible in all patients with suspected STEMI, in suspected ACS with other ECG changes or ongoing chest pain, and once the diagnosis of MI is made. I think this is something that we know and we are supposed to be doing, but it's been re-emphasized in the guidelines. The use of additional ECG leads, so right-sided leads V3R, V4R, when you have inferior MI, and also V7 to V9 when you have patients with posterior MI is recommended when you suspect this kind of occlusions or when the standard leads are inconclusive. And so additional 12-lead ECGs is recommended in cases of recurrent symptoms or diagnostic uncertainty. So if you read the paper, they didn't suggest the frequency at which you should repeat it, i.e. whether every 1 hour, every 2 hours. However, whenever there is that uncertainty, it is always good to repeat your ECG to clear doubts, because you may have a percentage of people who may not present the way you expect with respect to ECG changes. With respect to blood sampling, it is recommended to measure cardiac troponins with high sensitivity assays immediately after presentation and to obtain the results within 60 minutes of blood sampling. It's a recommendation. It's not practical in most places in Ghana. I don't know about Nigeria, but the chances of you getting your first troponin results within even 4 to 12 hours in most facilities is challenging. But this is the recommendation. It is recommended to use the ESC algorithm on the with serial HS troponin on the 0 hour, 1 hour, or the 0-2 hour rule. So the 2020 guidelines had the rule in and rule out, which is based on the troponin taken at the 0 hour and troponin taken at the 1 hour. So the 0 hour, 1 hour was what is recommended. It was seen to had a higher safety and also higher accuracy. However, you can do the 0-2 hours if the 0-1 hour is not feasible in your facility. The 0-3 hour, which was the older one, based on data, showed that it was inferior in terms of safety and accuracy compared to the 0-1 and 0-2. However, anytime there is doubts, based on the history and the presentation, you may still repeat the troponin on the 3rd hour. And that is what the additional testing after 3 hours is recommended if first 2 HS troponin 0 hour algorithm are inconclusive. But this is not practical in our setting, most settings in Ghana. I don't know about Nigeria. To get 0, yes, they say take the sample at 0 hour, 1 hour, or 0 hour and 2 hour. But the point is that you're unlikely going to get a sample at a time that patient has exceeded a window period that they will benefit from primary PCI. So you most of the times are forced to make decisions without, especially in the context of ST elevation. So maybe on the discussion, we'll get the perspective from Nigeria, whether this algorithm is feasible or applicable. And the use of established risk scores for prognosis should be considered. So there's TIMI, there's GRACE, but the ESC seems to use the GRACE even in the high risk and a risk stratification for the non-ST elevation acute coronary syndromes. So with respect to triage for emergency reperfusion strategy, it is recommended that patients with suspected STEMI are immediately triaged for an emergency reperfusion. So these are things that we know we have to do, but it's been put in context in terms of the guidelines. Now, with respect to non-invasive imaging and the initial assessment of patients with suspected acute coronary syndrome, an emergency transthoracic echocardiogram is recommended in patients with suspected ACS presenting with cardiogenic shock or suspected mechanical complications. And this is obvious. If you have a patient with ACS who is in shock, you want to look at the heart and rule out mechanical complications at least, or assess the left ventricular function. In patients with suspected ACS, non-elevated HS troponins, no ECG changes, and no recurrence of pain, incorporating the coronary angiogram or non-invasive stress testing is 2A, which this is what we stated earlier. It used to be a higher recommended class, but it was downgraded. Emergency TTE should be considered a triage in cases of diagnostic uncertainty, but they should not result in delays in transfer to the cath lab if there's suspicion of an acute coronary artery occlusion. Routine early coronary angiogram in patients with suspected ACS is not recommended. You have a patient with suspected ACS, we are pushing for a CT coronary angiogram. You should use it in the right context as described above, and not necessarily doing it routinely. With respect to the initial management, oxygen is only indicated when SATs are less than 90%. If it's above 90%, it is not recommended. With respect to pain relief, opioids should be considered as a 2A. You may give a mild tranquilizer to relieve symptoms in patients who are anxious. Beta blockade, metoprolol, if they are not having heart failure and their blood pressure, systolic blood pressure is greater than 120 and no other complications, should be considered 2A. But there has been some paper on the use of beta blockade post-MI in patients with preserved ejection fraction. I believe some of us have seen it where there was no real benefit in those who had preserved ejection fraction post-acute myocardial infarction. With respect to pre-hospital logistics, it is recommended that pre-hospital management of patients with a working diagnosis of STEMI is based on regional networks designed to deliver reperfusion therapy expeditiously and effectively, with efforts made to make primary PCI available to as many patients as possible. In Ghana, we don't have a really established, fully fledged established STEMI network yet, though we have hospitals and platforms that is communicated to that we help facilitate, but I won't call it an established STEMI network yet. It is recommended that primary PCI capable centers deliver a 24/7 service and able to perform primary PCI without delay, which of course is what is recommended. So I believe there may be challenges in developing country in terms of human resource and personnel, and also the items needed to do these 24/7 procedures. It is recommended that patients transferred for primary PCI bypass the emergency department and coronary care unit or ICU and are transferred directly to the cath lab. This is ideal, but in our setting, it doesn't happen most of the time. You have to go through the emergency, or you have to go through the National Cardiothoracic Center, depending on how you come. Sometimes you spend little time at the National Cardiothoracic Center where the cath lab is if the pre-hospital communication is good. So we prepare ahead, but if it's not good, we'll have to be certain, evaluate, check the indications, contract before we move you. So hardly will you come straight to the cath lab. It is recommended that EMS transfer patients with suspected STEMI to a PCI capable center, bypassing non-PCI centers. This is feasible in centers who have well-established networks and communications between these hospitals and the pre-hospital system is effective. We are not there yet in Ghana, so we are not able to implement that. It is recommended that ambulance teams are trained and equipped to identify ECG patterns suggestive of acute coronary occlusion and to administer initial therapy, including defibrillation and fibrinolysis when applicable. It is recommended that all hospital and EMS participating in the care of patients with suspected STEMI record and audit delay times and work together to achieve and maintain quality targets. With respect to invasive therapy for STEMI, reperfusion therapy is recommended in all patients with a working diagnosis of STEMI and symptoms of ischemia less than or equal to 12 hours, which is what is recommended. Primary PCI strategy is recommended over fibrinolysis if the anticipated time of diagnosis to PCI is less than 120 minutes. If timely primary PCI less than 120 minutes cannot be performed in patients with a working diagnosis of STEMI, fibrinolytic therapy is recommended within 12 hours of symptoms onset in patients without contraindications. And like I said, rescue PCI is recommended for failed fibrinolysis, which is ST segment resolution less than 50% within 60 to 90 minutes of fibrinolytic administration, or in the presence of hemodynamic or electrical instability, worsening ischemia, or persistent chest pain. Now, transfer to PCI capable center is recommended in all patients after fibrinolysis because they may need rescue PCI or they may need early angiography with or without PCI. Emergency angiography and PCI of infarct-related artery, if indicated, are recommended in patients with new onset or persistent heart failure or shock after fibrinolysis. Angiography and PCI of the infarct-related artery, if indicated, is recommended between 2 to 24 hours after fibrinolysis, and that is the early coronary angiography with PCI. That is 2 to 24 hours. In patients with a working diagnosis of STEMI and time from onset of symptom of more than 12 hours, a primary PCI strategy is recommended in the presence of ongoing symptoms suggestive of ischemia, hemodynamic instability, or life-threatening arrhythmias. In Ghana, most of our patients come beyond 12 hours. Hardly do we get patients coming within 12 hours. So we tend to do most of our emergency procedures 12 to 24 hours. In some situations, we have done 24 to 48 hours. A routine primary PCI strategy should be considered in STEMI patients presenting late, which is 12 to 48 hours, and this is informed by the OATS trial, which showed benefit up to 48 hours, but no benefits and more harm after 48 hours. Routine PCI of an occluded infarct-related artery is not recommended in STEMI patients presenting beyond 48 hours after symptom onset and without persistent symptoms. With respect to non-ST elevation, an invasive strategy during hospital admission is recommended with high risk criteria or high index of suspicion for unstable angina. A selective invasive approach is recommended in patients without very high or high risk and with low index of suspicion for non-ST elevation acute coronary syndrome. And like we mentioned earlier, an immediate invasive strategy as in less than 2 hours, similar to treating a patient with STEMI, even though the patient has a non-ST elevation, if he or she has one of the following, as we mentioned: in shock, hemodynamically unstable, refractory chest pain, life-threatening arrhythmias, mechanical complications. An early invasive strategy within 24 hours, which is 2 to 24 hours, should be considered in the high-risk group as compared to within 2 hours in the very high-risk group. This used to be a higher class, but now it's 2A. With respect to antiplatelet and anticoagulation, aspirin is recommended for all patients without contraindications at an initial loading dose of 150 to 300 and maintenance dose of 75 to 100 for long term. In all ACS patients, P2Y12 inhibitor is recommended in addition to aspirin, given as an initial oral loading dose, followed by maintenance dose for 12 months unless there's high bleeding risk. So maybe we can discuss this later, because if you look at the pre-treatment of the P2Y12 inhibitor before primary PCI, the level of recommendations was downgraded. However, here the recommendation is to, in ACS, to do both. So we can discuss that. A proton pump inhibitor in combination with dual antiplatelet therapy is recommended in patients with high risks of GI bleeding. Prasugrel is recommended in P2Y12 receptor inhibitor naive patients proceeding to PCI. And the question is for people above age 75, you need to have the dose or reduce the dose, or people with body weight of less than 60 kilograms. Ticagrelor is recommended irrespective of the treatment strategy, invasive or conservative. Ticagrelor is used, and clopidogrel is recommended when prasugrel or ticagrelor is not available or cannot be tolerated. So in terms of antithrombotic efficacy, prasugrel, ticagrelor, and clopidogrel. In terms of bleeding risk, prasugrel, ticagrelor, clopidogrel. So clopidogrel has the least risk of bleeding and also the least potency when it comes to antithrombotic effect. In patients presenting with acute coronary syndrome, you stop dual antiplatelet to undergo cabbage. It is recommended they resume after the cabbage. I think we've mentioned this earlier. This was part of the new revisions that they added. Prasugrel should be considered in preference to ticagrelor for ACS patients who proceed to PCI, and the GP2B3A receptors antagonists should be considered if there's no evidence of flow, that is the no reflow or thrombotic pump. So they are more for rescue, they are not for primary. They are like bailouts medications. Then P2Y12 inhibitor naive patients undergoing PCI, cangrelor may be considered, which is an IV P2Y12 inhibitor. In older ACS patients, especially those with high bleeding risk, clopidogrel as the P2Y12 inhibitor may be considered as it has the lowest bleeding risk. Pretreatment of P2Y12 receptor inhibitor may be considered in patients undergoing primary PCI, 2B, and pretreatment of P2Y12 inhibitor may be considered in non-ST elevation acute who are not expected to undergo early invasive strategy and do not have a high bleeding risk. For those who are going to have PCI, the pretreatment with P2Y12 showed no benefit in patients with non-ST elevation acute coronary syndrome. Pretreatment with GP2B3A receptor antagonist is not recommended. Like we said, it is for bailouts, and routine pretreatment of P2Y12 inhibitor in patients whom coronary outcome is not known and early invasive therapy is planned is not recommended. With respect to anticoagulants, parenteral anticoagulation is recommended for all patients with acute coronary syndrome at the time of diagnosis. Routine use of unfractionated heparin is recommended for patients undergoing PCI, mainly probably because of, if you take data, there may not be definitely significant difference, but unfractionated heparin, you can intervene, you can monitor your bleeding risk using your ACT, APTT, and others. So it's easy to work with in the cath lab. Intravenous enoxaparin at the time of PCI should be considered in patients pre-treated with subcutaneous enoxaparin. And if patient had last dose of enoxaparin more than 12 hours, it's good to repeat it before your PCI. Discontinuation of parenteral anticoagulation should be considered immediately after an invasive procedure. So immediately there's stenting, really there's no benefit in continuing the anticoagulation when the patient has been stented, except in some peculiar situations with, I think, bivalirudin. With patients with STEMI, enoxaparin should be considered as an alternative to unfractionated heparin in patients with STEMI undergoing PCI 2A. Bivalirudin with a full dose post-PCI infusion should be considered as an alternative to unfractionated heparin in patients with STEMI undergoing PCI. Fandoparinose is not recommended in patients with STEMI undergoing primary PCI. I think fandoparinose and the bivalirudin benefits were mentioned when a colleague of ours did the presentation on the anticoagulation. So fandoparinose for STEMI, no. However, in terms of non-ST coronary syndrome, the fandoparinose from the data showed better outcome compared to heparin, the enoxaparin. So for patients with non-ST elevation ACE in whom early invasive angiography is not anticipated, fondaparinux is recommended. For patients with non-ST elevation acute coronary syndrome in whom early invasive angiography is anticipated, enoxaparin should be considered as an alternative to unfractionated heparin. So it appears if you are certain of the primary PCI, unfractionated heparin is preferred over the low molecular weight heparin. Now, another area that always causes challenges when you have to combine the antiplatelet with anticoagulation post PCI. So, or in acute coronary syndrome. So, as the default strategy for patients with atrial fibrillation and CHA2DS2-VASc score greater than 1. So this will be changed because now we are not adding the sex, it's CHA2DS2-VASc. So we may have to contextualize it based on the current recommendations. Up to 1 week of triple antithrombotic therapy following the ACS event, then dual antithrombic therapy using NOAC at the recommended dose for stroke prevention, and single oral anticoagulant agent for up to 12 months is recommended. So basically, if you look at it, it's more informed about the risk of bleeding. So if the risk of bleeding is significant, triple therapy for 1 week. If the risk of bleeding is moderate, then you can do up to a month before taking out one antiplatelet and doing the oral anticoagulation with a single antiplatelet therapy. And in that context, clopidogrel is preferred because it has a lower risk of bleeding as a single antiplatelet when combined with anticoagulation. During PCI, unfractionated heparin bolus is recommended in any of the following circumstances: if the patient is on a NOAC, or if the INR is less than 2.5 in vitamin K antagonist treated patients. In patients with an indication for oral anticoagulation with vitamin K antagonists in combination with aspirin and or clopidogrel, careful regulation of the dose intensity of the vitamin K antagonist with a target INR of 2 to 2.5 and a time in therapeutic range greater than 70% should be considered. So this is balancing the risk of bleeding against the risk of thrombosis. So unlike if you were doing atrial fibrillation, you were doing 2 to 3, they've lowered the upper limit to 2.5 to minimize the risk of bleeding when you are doing triple therapy with vitamin K antagonists. When rivaroxaban is used and concerns about high bleeding risk prevail over ischemic stroke, rivaroxaban 50 mg daily should be considered in preference to 20 mg daily for the duration of concomitant single antiplatelet therapy or dual antiplatelet therapy. In patients with high bleeding risk, dabigatran 110 BD should be considered in preference to the 150 BD for the duration of concomitant single antiplatelet therapy or dual antiplatelet therapy to mitigate bleeding risk. In patients requiring anticoagulation treated medically, a single antiplatelet agent, in addition to the oral anticoagulant, should be considered for up to a year. In patients treated with an oral anticoagulant, aspirin plus clopidogrel for longer than 1 week up to 1 month should be considered in those with high ischemic risk or with other anatomical or procedural criteria that are judged to outweigh bleeding risk. So like I said, if you are doing the triple, you're either doing 1 week or up to a month. 1 week is for those who have high bleeding risk. The up to a month, they have relatively acceptable bleeding risk, but high risk of thrombosis, ischemic risk. So you may want to do the triple for a month before going to the oral anticoagulation and combining with a single antiplatelet therapy. In patients requiring oral anticoagulation, withdrawing antiplatelet therapy at 6 months whilst continuing oral anticoagulation may be considered. That is 2B. So this will still be balanced with your risk of thrombosis and the risk of bleeding. If you look at the other one that was recommended, it was up to a year, should be considered up to a year, but that was 2A, whereas the 6 months is what's 2B. It's all about balance. With de-escalation and shortening of dual antiplatelet therapy, we mentioned it's event-free, 3 to 6 months, and the risk of thrombosis or the ischemic risk is not high. You can do single antiplatelet, preferably a P2Y12 inhibitor. de-escalation of P2Y12 inhibitor treatment, that is switching from prasugrel, ticagrelor, which are very potent antithrombotic agents, to clopidogrel may be considered as an alternative if the bleeding risk is high. In high bleeding risk patients, aspirin or P2Y12 inhibitor monotherapy after a month of Duralant may be considered. So bleeding risk, or if you keep bleeding risk, thrombotic risk, or ischemic risk is mainly what defines what you do. And de-escalation of antiplatelet therapy in the first 30 days is not recommended post-ACS. Discontinuation of antiplatelet therapy in patients treated with an oral anticoagulant is recommended after 12 months. Adding a second antithrombotic agent to aspirin for an extended long-term secondary prevention should be considered in patients with high ischemic risks and without high. So there are patients that despite you've done 12 months of dual antiplatelet therapy, and ideally after 12 months, you don't necessarily have to continue the dual antiplatelet therapy. You have to reduce it to single antiplatelet. In some circumstances where you assess and you notice that the patient has very high ischemic risk, you may extend the duration. Adding a second antithrombotic agent to aspirin for an extended long-term secondary prevention may be considered in patients with moderate ischemic risk, similar to the other one, but the first one was those with high, this is moderate, so it was 2B, whereas the first was 2A. A P2Y12 inhibitor monotherapy may be considered as an alternative to aspirin monotherapy for long-term treatment, that is 2B. In terms of fibrinolysis, we've mentioned it. You want to give it when you don't have access to primary PCI within 12 hours, within 120 minutes, if it's indicated that the patient qualifies for revascularization, and the options is tenecteplase, alteplase, reteplase. In Ghana, we tend to get more of the tenecteplase, even though it's very expensive, and most patients also do not come within the window period to benefit from thrombolysis, which is within the 12 hours. And in elderly patients, the risk of bleeding is high, so you need to have the dose of tenecteplase. You continue aspirin and clopidogrel when you are doing fibrinolysis. The anticoagulation is continued until revascularization is performed, or you do up to 8 days. Enoxaparin IV followed by subcutaneous is recommended as the preferred anticoagulant in case of anticoagulation therapy with fibrinolysis. When enoxaparin is not available, unfractionated heparin is recommended. In patients treated with streptokinase, an IV bolus of fandopirinus followed by a subcut dose 24 hours later should be considered. And in cardiac arrest, we mentioned that primary PCI strategy is recommended in patients who have resuscitated cardiac arrest and ECG showing persistent ST elevations. For those showing no persistent ST elevation and hemodynamically stable, it is not recommended. We spoke about the temperature control earlier. Systems of care and neurological prognosis have also been mentioned earlier. With respect to cardiogenic shock, immediate coronary angiography and PCI of the infarct-related artery is recommended. Emergency CABG is recommended if PCI is not feasible or is unsuccessful. And this can only be done in centers who are been doing CABG in the acute setting because of the high risk of mortality, perioperative risk. In cases of hemodynamic instability, emergency surgical or catheter-based repair of mechanical complications of ACS is recommended based on heart team discussion. Fibrinolysis should be considered in STEMI patients presenting with cardiogenic shock if a primary PCI strategy is not available within 120 minutes from the STEMI and mechanical complications have been ruled. I think this has already been made clear. In patients with ACS and severe or refractory cardiogenic shock, short-term mechanical circulatory support may be considered. And the studies that have looked at the use of the intra-aortic balloon pump and other circulatory support devices in acute coronary syndrome with PCI the outcomes have not been that superior to using without those mechanical devices. And I think that informed the decision to be 2B. The routine use of intra-aortic pump in ACS with CS and without mechanical complications is not recommended. Now, with logistical issues, which mostly will be a challenge in our setting, it is recommended that all hospitals participating in the care of high-risk patients have an ICU or a CCU with all the necessary equipment, which we agree with, but mostly not feasible on ground. It is recommended that high-risk patients, including STEMI patients and very high-risk non-STEMI, have ECG monitoring for a minimum of 24 hours. It is recommended that high-risk patients with successful reperfusion therapy and uncomplicated clinical course are kept in the CCU or ICU for a minimum of 24 hours, after which they may be moved to a step-down monitored bed for 48 hours, which this is obviously something that we have to, because we know what can happen within that 48-hour window period, the risks of arrhythmias, cardiac arrest, etc. Discharge of selected high-risk patients within 48 to 72 hours should be considered if early rehabilitation and adequate follow-up are arranged. Same-day transfer in selected stable patients after successful and uneventful PCI should be considered. And we have never discharged a patient on the same day for an acute coronary syndrome, which we've had primary PCI. Routine echocardiography is recommended during hospitalization to assess regional and LV global function, detect mechanical complications, and exclude LV thrombus. It's a class 1. And when echocardiography is suboptimal, MRI is not compulsory, it's 2B. Drug-eluting stents are recommended in preference to bare metal stents. I believe most facilities now, even in developing countries, are using drug-eluting stents. In patients with spontaneous coronary artery dissection, we mentioned earlier on its conservative approach, and PCI should only be considered when these symptoms are present. We spoke about the use of intravascular imaging in the earlier new recommendations. Cabbages should be considered if the infarct-related artery is not amenable to PCI, or PCI was not successful and a large area of myocardium is at risk. I don't know about Nigeria, but we are yet to have a situation where our surgeons have done an emergency cabbage for ACS. Intravascular imaging may be considered. We are not using intravascular imaging as of now, and the routine use of thrombus aspiration is not recommended. Radial access is recommended unless there are overriding procedural considerations, and PCI with stent deployment in the infarct-related artery during the index procedure is recommended in patients undergoing PCI. This is obvious. With respect to management of multivessel disease, it is recommended to base the revascularization strategy on the patient's clinical status, comorbidities, as well as the disease complexity, according to the principles and management of myocardial revascular. So this is just telling us what ideally we are supposed to be doing and placing it in a recommendation. In patients with cardiogenic shock, the infarct-related only PCI during the index procedure is recommended. Stage PCI of the non-infarct-related should be considered as a 2A. So we don't need to be doing heroic things when they are in shock. We stent the infarct-related artery and we come out. Complete revascularization is recommended in patients who are hemodynamically stable. So both the infarct-related artery and the non-infarct-related artery can be stented if the non-infarct-related artery meet the criteria for revascularization, either the procedure or within 45 minutes, which we had mentioned earlier on. And invasive epicardial functional assessment of non-corporate vessels is not recommended. And for non-ST elevation acute coronary syndrome with multivessel disease, hemodynamically stable, complete revascularization should be considered. preferably during the index procedure. It's a 2A. Functional invasive evaluation of non-infarct related severity during the index procedure may be considered, which is a 2B. With respect to myocardial infarction with non-obstructive coronary MINOCA, cardiac MRI is recommended after invasive angiography if the final diagnosis is not clear. Management of MINOCA according to the final establishment is recommended because MINOCA we know may be due to several causes. So depending on the underlying cause, we do cause-specific management. In all patients with an initial working diagnosis of MINOCA, it is recommended to follow a diagnostic algorithm to determine the underlying final diagnosis. With respect to complications, an intra-aortic balloon pump should be considered in patients with hemodynamic instability or cardiogenic shock due to ACS-related mechanical complications. It's a 2A. Cardiac MRI imaging should be considered in patients with equivocal echocardiographic images or in cases of high clinical suspicion of LV thrombus. 2A. Oral anticoagulation should be considered 3 to 6 months in patients with confirmed LV thrombus. Following an acute anterior MI, a contrast echocardiogram may be considered for the detection of LV thrombus if the apex is not well visualized and is a 2B. In patients with atrial fibrillation, intravenous beta blockers are recommended when rate control is needed in the absence of acute heart failure or hypotension. Intravenous amiodarone is recommended when rate control is needed in the presence of acute heart failure and no hypotension. Immediate electrical cardioversion is recommended in patients with ACS and hemodynamical instability and when adequate rate control cannot be achieved promptly with pharmacological agents. Intravenous amiodarone is recommended to facilitate electrical cardioversion and or decrease risk of early recurrence of AF after electrical cardioversion in unstable patients with recent onset AF. In patients with documented de novo AF, during the acute phase of acute coronary, long-term oral anticoagulation should be considered depending on the CHART-VASC, now CHART-VA, after taking the Hasbled score and the need for concomitant antiplatelet therapy into consideration. With respect to ventricular arrhythmias, we've discussed this previously. ICD therapy is recommended to reduce sudden cardiac death in patients with symptomatic heart failure, New York Heart Class 2, 3, EF less than or equal to 35, despite optimal medical therapy for 3 months and at least 6 weeks after MI. So this has been discussed severally in our previous discussions. Intravenous beta blocker and or amiodarone treatment is recommended for patients with polymorphic VT and or VF unless contraindicated. Prompt and complete revascularization is recommended to treat myocardial ischemia that may be present in patients with recurrent VT or VF. A transvenous catheter pacing termination and or overdrive pacing should be considered if VT cannot be controlled by repeated electrical cardioversion. Radiofrequency ablation at a specialized center followed by ICD implantation should be considered in patients with recurrent VT or VF or electrical storm despite complete revascularization and optimal medical therapy. Treatment of recurrent VT with hemodynamic relevance despite repeated electrical cardioversion with lidocaine may be considered if beta blockers, amiodarone, and overdrive stimulation are not effective. In patients with recurrent life-threatening ventricular arrhythmias, sedation or general anesthesia to reduce sympathetic drive may be considered. ICD implantation or temporary use of a wearable cardioverter defibrillator may be considered less than 40 days after MI in selected patients, i.e. incomplete revascularization, pre-existing LVEF dysfunction, occurrence of arrhythmias greater than 48 hours after STEMI onset, polymorphic VT or VF. So the idea here is we can only put in ICD based on the recommendation is 3 months after optimal medical therapy, or the earliest will be 6 weeks if EF is less than 35%. However, if it's less than this, 40 days, and the patient has this, then the wearable cardioverter defibrillator can be used. Dissenting opinions, 2B. Treatment of asymptomatic and hemodynamically irrelevant ventricular arrhythmias with antiarrhythmic drugs is not recommended. In terms of bradyarrhythmias, in case of sinus bradycardia with hemodynamic intolerance or high-grade AV block without stable escape rhythm, IV positive chronotropic medication, adrenaline, vasopressin, and or atropine is recommended. Temporal pacing is recommended. In cases of failure to respond to atropine, urgent angiography with a view to revascularize is recommended if the patient has not received previous reperfusion therapy. And like it was stated earlier, permanent pacemaker is recommended for high-grade AV block if it doesn't resolve within 5 days after MI. And this is a repetition when we mentioned the new reviews for selected patients with high degree AV block in the context of an anterior wall MI and heart failure. Early device implantation, CRT-D or CRT-P, may be considered. We discussed the indications of CRT in our previous discussions, and we know that it should have been after optimal medical therapy for at least 3 months with EF persistent less than or equal to 35%, and patient meeting the criteria either by band of bunch block, LBB, preferably greater than or equal to 150, or the indications for some people between 130 to 150. And so I believe we did that discussion. Pacing is not recommended if high degree AV block resolves after revascularization. And with respect to chronic kidney disease, the risk of contrast nephropathy, so the use of low or iso or smaller contrast media is recommended. It is recommended to assess the kidney function in patients with ACS. It is recommended to apply the same diagnostic and therapeutic strategies in patients with CKD as in patients with normal kidney function. Hydration during and after angiography should be considered in patients at risk of contrast-induced nephropathy, especially in patients with acute kidney injury and or CKD with eGFR of less than 30. With respect to diabetes, it is recommended to base the choice of long-term glucose lowering treatment on the guidelines, which recommend considering heart failure, CKD, and other parameters. It is recommended to assess glycemic status at initial evaluation, since we know hyperglycemia is associated with poor outcomes. It is recommended to frequently monitor blood glucose levels in patients with known diabetes mellitus or hyperglycemia with glucose of greater than or equal to 11.1. Glucose lowering therapy should be considered in patients with ACS with persistent hyperglycemia. This was among the reviews. The 2020-2017 mentioned specifically to keep it less than 10, not above 10, but the new guideline says we should lower it, but with not a particular cutoff, but prevent hypoglycemia. In older adults, it's recommended to apply the same diagnostic and treatment strategies in older patients as in younger patients, to consider the renal function, comorbidities, frailty, cognitive functions in managing these patients. And for patients with cancer, we stated if life expectancy is less than 6 months, they don't benefit from the invasive strategy. And you may interrupt anti-cancer therapy if you think it's contributing to the ACS. And for less than 6 months, conservative, we've described the cutoff of platelets for the various P2Y12 antagonists and also aspirin earlier on. Then cardiac rehabilitation, which is something that has been shown to improve outcomes in ACS, heart failure, and other cardiovascular diseases, should be established in our facilities. and is multidisciplinary. It entails both pharmacological and non-pharmacological pillars. Lifestyle management is essential as part of secondary prevention. With respect to lipid, we said the target LDL is less than 1.4 because they have an established ASCVD risk. And if you're unable to achieve that target, you have the role to add other medications. PCSK9 inhibitors, ezetimibe, are all part of the recommendations. For patients with recurrent arterial thrombotic events, i.e. recurring within 2 years of first ACS, while taking maximum tolerable statin-based therapy, your LDL goes to less than 1 instead of the 1.4. Combination therapy with high-dose statin plus ezetimibe may be considered during the index hospitalization. We've mentioned this earlier. And beta blockers are recommended in ACS EF less than 40%. And routine beta blockers for all ACS patients, regardless EF, should be considered was 2A, but with the new trial showing no benefit in those with preserved EF, this may be reviewed. And ACE inhibitors are recommended with heart failure, EF less than or equal to 40%, diabetes, hypertension, and CKD, MRA less than or equal to 40%, and heart failure and DM. Routine ACE inhibitors in ACS should be considered, and polypill should be considered as an option to improve adherence and outcomes. With respect to imaging, in patients with pre-discharge EF of less than or equal to 40%, repeat evaluation at 6 to 12 weeks after ACS, after complete revascularization, and institution of optimal medical therapy is recommended to assess the potential need for sudden cardiac death, because you are going to evaluate the possibility of ICD after 3 months, which is averagely 12 weeks. So a repeat echo to assess whether the EF is less than or equal to 35%, which will inform your decision for ICD or CRTD is important. Cardiac MRI should be considered as an adjunctive imaging modality in order to assess the potential need for primary prevention with ICD implantation. That's 2A. Influenza vaccination is recommended for all ACS patients. It's not something that we do in Ghana or I'm aware of. Low dose colchicine was mentioned earlier in patients who have had the other risk factors modified but still having insufficiently we are not achieving their targets, or the risk of cardiovascular disease still very high. You may consider low dose colchicine. So 2. And in terms of patient perspectives, I think we discussed this already. This is just to re-emphasize it. I just added this slide. This is from the 2020 to let us appreciate when we say high sensitive troponins, what it entails. They have higher negative predictive value for MI. They reduce the troponin blind interval, leading to early detection. So troponins can rise within the first hour and to pick it up. And so they minimize delay in diagnosis and transfer of patients. With respect to the cutoff, I don't know about Nigeria, the recommendation is the 99th centile of the upper limit range. However, most labs in Ghana do not state the 99th centile that they are using. So you don't know. I know of only one lab that does that. So it's difficult to sometimes tell whether your patient actually has MI by definition, if you want to use the fourth definition, what's the 99th centile for the upper limit range for that assay and population is not known. However, elevations beyond 5-fold gives you a positive predictive value of 90% for type 1 MI. And 3-fold, you're looking at 50 to 60% positive predictive value for high sensitive troponin. So I just thought bringing it up may help us. And also, we should always think about other causes of ACS when someone is coming with acute chest pain. So these are possible differentials that we should think of: cardiac, pulmonary, vascular, GI, orthopedic, others. These have all been shown as good differentials. So when we are taking a history or evaluating patients, we should think about these and not only think it's ACS. Thank you very much.
Okay, thank you so much, Dr. Eugene Mfofo, for that extensive presentation. Well appreciated. Okay, so the floor is open to questions, is open to contributions as regards this presentation. Okay, before others come up, okay, Dr. Eugene, okay, as regards the bleeding, I didn't really get in what hierarchy do we place clopidogrel, ticagrelol, and there's a third one you mentioned, like in the yeah. So please, can you repeat it, because I know that's an MCQ question.
So prasugrel,
which is best to be used post PCI?
Prasugrel has the highest potency when it comes to antiplatelet effects, followed by ticagrelol and then clopidogrel. So clopidogrel has the lowest antiplatelet effects. You understand? Whereas prasugrel is the highest. Then when it comes to the risks of bleeding, prasugrel has the highest risks of bleeding, followed by ticagrelol and then clopidogrel. So clopidogrel is the lowest in everything. The lowest when it comes to antithrombotic or antiplatelet effect, and also the lowest risks of bleeding.
Okay. Thank you. So now in the aspect of the best antiplatelet to be given post PCI is what we are going with what ticagrelol or prasugrel.
In terms of data, prasugrel and ticagrelol are superior to clopidogrel as a P2Y12 in ACS. However, the risk of bleeding is what will inform your decision. Ticagrelol is in between; it's a balance. So for me, if you are not, if you can afford, your facility can stock ticagrelol, patient can afford ticagrelol, is a balance. The risk of bleeding against the benefit, its antithrombotic effect, is in between that of prasugrel and clopidogrel. You know, clopidogrel, there are a group of people who are non-responders to clopidogrel, and also clopidogrel is a prodrug compared to ticagrelol and prasugrel. So if the anatomy is not known, then prasugrel is not what is recommended because of the risk. But whether you know the anatomy or not, ticagrelol can be used. So ticagrelol can be used across board if you have a balanced risk. But if your risk of bleeding is high, then the go-to drug will be clopidogrel.
Okay, because I know that MCQ actually had ticagrelol, it had prasugrel, and the answer was ticagrelol. That's the best antiplatelet following post PCI. Okay, so my second question, there was another MCQ we saw about door to balloon time. We were confused whether it's 90 minutes or 120 minutes. I think from your presentation, I'm saying 120 minutes.
No, so the 120 minutes defines whether you are going to do a primary PCI strategy or not. So a patient has come with STEMI, less than 12 hours, clearly needs revascularization. Okay, you've made the decision. You are the first medical center seeing the patient. Can you offer this patient PCI? If the answer is yes, you offer the patient the PCI. That is what is preferred. But if you can't offer the patient PCI, okay, I can't offer the patient PCI, but a hospital, the next hospital can offer PCI. How far is that hospital? If that hospital is within 120 minutes, then refer the patient for primary PCI in that hospital. However, if that hospital is more than 120 minutes from you, initiate your medical therapy, do your checklist to see if the patient has no contraindication for thrombolysis. Then thrombolize the patient. Now, if you thrombolize the patient, you need to still send the patient to the hospital that can do invasive coronary angiography with or without PCI. The reason is that after thrombolysis or fibrinolysis, it may be successful or it may fail. And to confirm whether it's successful or failed, you confirm in 60 to 90 minutes using your ECG. So less than 50% reduction in ST elevation in 60 to 90 minutes means it's failed. More than 50% means the thrombolysis was successful. But you don't want to keep the patient for that 60 to 90 minutes. So after your thrombolysis, still refer. The receiving facility will assess whether your thrombolysis was successful or not. And if your thrombolysis was not successful, the patient will be offered immediate PCI, which is a rescue PCI, because it was not successful. However, if your thrombolysis was successful, then the patient will be offered early angiography with or without PCI, depending on what they see. And the early means 2 hours to 24 hours, whereas the rescue PCI is within 2 hours. So the door to needle or door to balloon is the facility that is doing the PCI. So if facility A is the one doing the PCI, when the person gets to the door of that hospital that does the PCI, what time does it take for that patient to get to the cath lab and for the wire to cross the lesion? And that is what is being recommended to be 60 to 90 minutes. However, some facilities are aiming at 30 minutes, 10 minutes. The lower, the better. So it is, if the person gets to the entrance or that facility that can offer PCI, what time does it take for that patient from the door to go and lie on the table in the cath lab and to have the wire cross the lesion? That is the door to balloon. And there has been 60 to 90 minutes. Some have even proposed 30 to 60 minutes, but most references look at 60 to 90 minutes. But facilities are competing among themselves and looking at a lower timeline. Whereas if you offer to give thrombolysis as your option because you could not do PCI, then because the thrombolysis is a needle in quotes, that's what is called door to needle time. The door to needle, like you decide to do thrombolysis, then within 30 minutes to 60 minutes, you should have offered thrombolysis. If you look at the recommendation, they are looking at even less than 10 minutes.
Okay, thank you so much. So, okay, you're saying that we should work with within 90 minutes for door to balloon time, 60 to 90.
Yeah.
Okay, then door to needle
30
within
to 60.
30 to 60 minutes.
Yeah.
Okay, just a recap. Let me be sure if I got that right. You made mention of post PCI that we can actually give double antiplatelet for 3 to 6 months. Thereafter, we give a P2Y12.
In patients who are event-free. So the decision on dual antiplatelet therapy post-PCI, though there is benefit, is informed by the patient's ischemic risk and bleeding risk, and whether the patient has an event or not. So if you've done a PCI with a drug-eluting stent and you put the patient on a dual antiplatelet, you know the recommendation had been minimum of 6 months with a target of 12 months. So most people, 12 months was acceptable. Now, it's been shown that if patients had no events post your PCI within 3 to 6 months, and there is the risk of ischemia, i.e., the risk of the person having another MI or the risk of the stent getting blocked, is not high. In such patients, you can consider stopping the dual antiplatelets and doing a single antiplatelet therapy. And that single antiplatelet therapy, the preference is a P2Y12 inhibitor.
Okay, thank you so much, Dr. Eugene. Thank you so much. Okay, so I'll go into the chat room because I'm not seeing electronic hand up. Okay, so in the chat room, Dr. Mokorede Ayodeji, applauding you for an excellent presentation, as well as Dr. Itubi is saying thank you very much for an excellent presentation. So Dr. Laleko is saying thank you for this excellent presentation. What is the recommendation of acute coronary syndrome in pregnant patients? What do we recommend for a patient who is pregnant with ACS?
Okay, thank you very much. Thank you. In fact, I saw the question and I started scratching my head. Thank you, Senior. But in terms of the recommendations I went through, I don't remember seeing recommendations in pregnant women. So it might have been in and I missed it, but I didn't see it. So if anything I say will be more of like a conjecture based on theory. So I can go and check and come back to the group. But if someone else has the recommendations on that, the person can make it known. Thank you.
Or don't you think they'll weigh the risks and the benefits?
Oh, they would. That if I try explaining it will be theoretical based on what I've read, but in terms of what has been recommended based on the guidelines, I didn't see that. But it is definitely going to be on the risk of ischemia, bleeding, not just the mother now, but you're looking at the risk of bleeding also in the baby, because you are going to use dual antiplatelet with unfractionated heparin. So the risks of bleeding and a placenta, bleeding, placenta bleed, etc. You have to strike a balance. But like I said, it will be theoretical if I'm to answer it based on what I've read. But in terms of recommendations specifically by ESC, I don't remember seeing that.
Okay, thank you. So Dr. Oladekun, do you have anything to say about that? Any response as regards that?
Okay, thank you. Yes, from the guideline, what was just stated was that, okay, first of all, the diagnostic criteria for both pregnant and non-pregnant patients are the same. And then the management should be requirement of the multidisciplinary team that's consisting of the cardiologists, obstetricians, anesthesiologists, and then neonatologists. And then they should patients that are pregnant should probably be managed in an intensive care unit. And because of the increased risk of maternal mortality, so then there is need for maternal monitoring as well as obstetric care. And then the treatment of the acute coronary syndrome should not delay delivery. And then another thing that was stated was that delivery should be ideally postponed for at least 2 weeks post ACS, as there is an increased risk of maternal mortality during this during the period. I think those are basic things that I actually noticed under pregnancy, as pertaining to the management of ACS.
Sorry, Dr. Oladekun, let me get you right. If this patient is in her early trimester or early, let's say, first trimester or early second trimester, what do we do? I didn't really get you so well. Are we terminating the pregnancy, or what are we doing? Sorry.
Okay, well, it wasn't stated whether to terminate the pregnancy or not. I think the decision should be taken by the multiple teams, that's including the cardiologists, obstetricians, and then the anesthesiologists, and considering the, I think the risk of mortality or morbidity. That was what was actually stated. But whether to terminate the pregnancy based on probably the first or second trimester, I didn't say such. Probably I need to actually search for that. But I think what I probably in relation to those that probably are in the third trimester or probably term, in relation to delivery, that there will be need to set up team, not just the management just based on the intervention or the cardiologist. You need to also involve the obstetrician as well as the anesthesiologist in the management. I think those were the major things that I actually saw there.
Okay, thank you so much. Thank you so much. Okay, so I would like to call on, I'm not seeing any hand up, so I would like to call on Dr. Uzoke, whether he has any contribution to this from his experience to this particular topic being taught. Chief Cyril, anything to say that we should think keynotes?
Thank you very much. Thank you.
Okay, Dr. Onyebueze, Chief Onyebueze, do you have anything for us to know, like something we should know about this topic?
Essentially, he has there's a guideline topic. Essentially, has spoken everything that needs to be known. The only area is just that issue of pregnancy, early pregnancy, and then early stage of second trimester. Multidisciplinary approach most times will now determine whether to terminate the pregnancy, because most times you find out that that pregnancy may not be viable continued with the treatment for ACS.
Okay, thank you so much. Thank you so much. I appreciate. Okay, Chief Itubi, any emphasis, because this was quite a very extensive, this is like emphasis that you think we should not joke with. Thank you.
Thank you very much. Good evening, seniors and colleagues. I think the discussion on the guideline was quite extensive by him. Few aspects that I think would be knowing which antiplatelet to use, which Dr. Florence started asking about. That is key and important. And then knowing the duration of when to assay for some of those markers like the troponin, how long they last for, and then if you have a reinfarction, what you would like to check. But essentially for the guidelines, the key things have been touched on. But when we're looking at ACS, good to always remember when we have a reinfarction, what do we check out for? And then the other aspect is looking at the breakdown of the types, type 1 to 5. So to know, for example, they give MCQs that try to test if we know which type a particular description or a scenario would fall into. Is it a form of a direct mismatch, or is it resulting from another cause? That kind of aspect. But for the guidelines, Dr. Eugene has extensively discussed it, and I think it is something we should look all over again, especially paying attention to the adjustments or the newer recommendations and that were made to the previous one from the 2023 ESC guideline. Thank you very much.
Okay, thank you so much, Dr. Itubi. Okay, Dr. Grace, do you have anything to say, like emphasis that should be laid on? Emphasis, Dr. Grace Akere Dolu. Thank you.
Good evening, everybody. Basically, every aspect is important as we've been keeping in view all the different parts from investigation to medication use and all that. They can come out in MCQ, and different aspects different scenario can be painted both at the onset of the acute event. They can paint a scenario and talk about management. Complication too can be painted, and we can be asked to manage. That can come out also both in MCQ and in the oral. I think there is an oral question on a complication on with stenosis. So we should know what we're expected to do, how to investigate, and then the definitive management. So all aspects of this discussion is important, and they are relevant both for the MCQ and the oral section. Thank you.
Thank you so much. Okay, Dr. Ayodeji. Dr. Ayodeji.
Yeah, thank you, everyone. And just to reiterate what has been said, we should just pay attention to the antiplatelet, which for both especially the MCQs, for patients with high bleeding risks, those that are pro-drug, those that has a reversible, irreversible ones, and also even the IV, then maybe for the management has been, Dr. Eugene has done justice to it too. So you should just pay attention. And then some of terminologies, the rescue PCI, facilitated PCI, primary PCI, the dot to needle and the dot to, I think we should just know that. Thank you.
Okay, thank you so much, Chief Ayodeji. So I'm going to call on Chief Godia. Chief Godia. Chief Godia. Okay, Chief Godia. All right. Okay, so in the absence of further questions, because our chiefs I'm not seeing any more chief here. So in the absence of further questions and contributions, we'll move over to Dr. Doctor, I don't know whether we're going to, since we don't have any of our chiefs here. Dr. Conte. Dr. Conte?
Yes, Florence.
I don't know. Our chiefs are not here. Should Dr. John go on with his number? He can go on, right? For 10 minutes. What do you think?
You know, the inputs of our chiefs will be very, very important as to how we tackle the question what are the next thing. So I think we can shelve it to when we take the next set of orals.
Okay.
Yeah.
Okay, that's on